Woolfield.
I'm Carla Pecoraro.
And I'm Mel Akerman, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Welcome to our third episode on caesarean sections. Today, we'll cover complex caesarean sections and share strategies for some of those more difficult deliveries.
I hope you're not bored yet.
Now, while most caesarean sections are quite straightforward, we do get the occasional baby that makes us work up a sweat. Some babies can be quite tricky to deliver, and a difficult delivery is associated with increased maternal and neonatal morbidity. It's really important that we anticipate these deliveries, take steps to prevent difficulties from occurring, and make sure we have a good plan for managing them if they do. So, what are the situations where we might anticipate a difficult fetal delivery?
Cases where delivery of the baby might be difficult include where there's a deeply impacted fetal head, where the fetal head is floating, in the case of an extremely low birth weight fetus, where the baby is breech or in a transverse lie, or in the presence of a low anterior placenta, or when there is a uterine constriction ring. In these situations, I always make sure I go through a delivery plan in my head, have a consultant and paediatrician ready in attendance, let the anaesthetist know to have GTN ready, and have a backup plan if the baby doesn't come easily.
Okay, let's face our biggest fear first, the deeply impacted fetal head. What is an impacted fetal head, Mel?
An impacted fetal head occurs when the fetal head descends into the vagina but does not progress any further. The vaginal tissues conform to the head, creating a suction cup-like effect that makes elevating the head quite difficult, and there is not enough space between the symphysis pubis to get your hand in to allow delivery with the usual maneuvers. An impacted fetal head occurs most often at full dilatation, but is not exclusive to fully dilated deliveries and can even happen in non-labouring women.
I can hear my heart beating very loudly in my ears. It's just heart-stopping. There's nothing worse than an unexpected impacted fetal head. How often does it occur?
An impacted fetal head is estimated to occur in 1.5% of all births, although this can be up to 10% of unplanned caesarean sections and 16% of second-stage caesarean births. The fetal head is more likely to become impacted with fetal malposition, prolonged labour, oxytocin augmentation, obstructed labour, or at a low fetal station.
Now, the reason we worry about an impacted fetal head is firstly because it is incredibly difficult to disimpact a fetal head and get the baby out, and secondly because of the increased risks to both mother and baby. Impacted fetal head is associated with maternal trauma like uterine extension, damage to the uterine vessels, cervix or vagina, postpartum hemorrhage, and bladder and ureteric injuries. For the baby, increased force used to deliver the baby can result in skull fracture, intracranial hemorrhage, nerve injury, neck fracture, HIE, and even death.
So obviously, we want to do everything we can to avoid causing harm to mum or baby. But we also need a way to get the baby out. What kind of tips and tricks do you have for the deeply impacted head?
Firstly, we want to be doing a vaginal examination when we're in theatre, before we start the caesarean section. This should be done by the most senior obstetric doctor present, immediately prior to commencing the caesarean. Now, the reason we do this is to check whether that the head is descended any lower, which might make vaginal delivery possible, but also to apply steady, firm upward pressure to assist with disengagement of the fetal head. A fetal pillow can and should be used where possible as well, and we'll go into this a bit more later.
We also want to make sure we have the right staff on hand. These difficult deliveries should have an experienced obstetrician and a paediatrician in attendance or readily available whenever a technically difficult delivery is anticipated. RANZCOG actually suggests that a consultant obstetrician be present for all fully dilated caesarean sections, although there's no actual evidence that consultant presence makes a difference to outcomes. The anaesthetist should also be prepared for the possibility of needing tocolysis or for the management of PBH.
Once you're actually doing the caesarean, you want to firstly make sure you've created enough space to deliver the baby safely. The last thing you want to be doing is a Maillard's procedure, which is cutting the rectus muscles, because you made your incision too small. These deliveries are challenging enough without making it harder on yourself with a laparoscopic incision. The next thing to think about is where you put your uterine incision. I'm always told to go higher than I think. Why is this?
When the cervix is fully dilated, sometimes the lower uterine segment can actually be higher than if you're performing a caesarean section early labour. If you cut in your usual position or too low, then you might actually be cutting into the cervix. This increases the risk of preterm birth and cervical incompetency in future pregnancies. Or worse, you might even be cutting into the vagina. In there are 3 techniques to deliver a deeply impacted head: the push technique, the pull technique, and Pat Wyden's maneuver. Let's start with the push technique.
In the theme of threes, there are also 3 variations of the push technique. The push technique requires steady and firm upward pressure on the fetal head. Now, this can be done by the surgeon with your fingers passing between the head and the uterine wall to below the head and exerting upward pressure. If it doesn't work with your dominant hand, sometimes changing to your non-dominant hand can help you to get a better angle to disimpact that head. To get that angle right, you may need to turn your body towards the patient's head. Sometimes placing your hand laterally can be helpful too. The transverse diameter of the maternal pelvis is wider than the AP diameter, so if there's no space anteriorly, you might still be able to get your hand in laterally to disengage the fetal head. Remember to keep that wrist straight. Flexing the wrist can result in maternal injuries and cervix laceration.
And don't forget to use tocolysis, which can be helpful in stopping contractions, which are counterproductive at this point. But it also relieves some of the pressure on the upper uterine segment, which is typically retracted after your uterine incision. I usually make sure my anaesthetist has GTN ready to go before I make my skin incision. Although you can use salbutamol, terbutaline, or a deep GA as your tocolytic as well.
The second way of doing the push technique with a woman in semilithotomy is with an assistant placing firm upwards pressure on the fetal head with a cupped hand. This is also termed an abdomino-vaginal delivery. I do find a lot of people are really quite reluctant to be the person who actually does the push method, and I think this stems from a coroner's report involving a fetal injury from this procedure. So if you think you might need to use this technique, then you really want to make sure that there's someone in the room who's confident, capable, and willing to perform the maneuver before you start the procedure. Now, it's really important that if you're the assistant doing the push method, that you try and distribute the pressure across your whole hand rather than just 1 or 2 fingers, as this is what reduces the risk of fetal injury. Ideally, the woman's leg should be positioned in semilithotomy with the knees flexed, thighs abducted. The assistant exerts upward pressure while the surgeon provides steady upward traction on the fetal shoulders and attempts to flex the fetal head.
And the third method of the push technique is to use a fetal pillow.
Hallelujah, hallelujah. The fetal pillow, what an invention. The fetal pillow is a soft silicone balloon on a firm backing. It's inserted in theatre at the time of the final VE. You hold the device by the wings between the thumb and the forefinger, lubricate it with some obstetric cream, and you really want to tuck it up high underneath the fetal head, between the head and the coccyx. The legs are put back into position and the pillow is inflated with 180 ml of sterile saline. The idea is that the pillow evenly distributes the upward pressure on the fetal head to elevate it by 3 to 4 centimeters and to reduce the risk of injury to the baby.
The fetal pillow was invented by Dr. Rajiv Varma from Brigham and Women's Hospital in Boston, following the tragic death of a baby at his hospital due to skull fractures because of difficulties in delivering the head at a second-stage caesarean section. He came up with the idea sometime before 2006 and launched a company called Safe Obstetric Systems specifically to develop the fetal pillow. As with most inventions, it takes a while to bring it to fruition, so the device was released in 2011.
Since its release, there have been a few studies looking at the efficacy of the fetal pillow. These are nicely summarised in a systematic review in the ARCOG Scientific Impact Paper number 73, Management of Impacted Fetal Head at Caesarean Section, published in June 2023. This review concluded that the fetal pillow was associated with a shorter incision to delivery interval, fewer extensions of the uterine incision, and less NICU admissions. There was conflicting evidence on the impact on blood loss. I use a fetal pillow for all fully dilated Caesars, and I consider it for all caesareans with a dilatation over 8 centimetres. Although it's important to note that the role of the fetal pillow in preventing impacted fetal head in first-stage caesarean births has not been assessed. Also, the fetal pillow is not useful when an impacted fetal head is encountered unexpectedly. Something that people always notice is that if you've put it in correctly, once you blow the balloon up, you might notice some liquor coming out. Everyone's like, oh, what's happening? What's all that? And it's like, yes, good. It's working. It's what I want.
It's a good sign. Okay, so what happens if my push method doesn't work? So I've got my fetal pillow in, I've tried disimpacting the fetal head with my dominant hand, I've tried going laterally, the anaesthetist has given GTN, I've turned around and tried using my non-dominant hand to see if I could get disimpaction with that. I'm getting really sweaty, my heart is beating. What do I do now to get this baby out?
Okay, now we want to be thinking about the pull method, otherwise known as the reverse breech extraction. This technique involves grasping one or both of the fetal feet at the fundus of the uterus and applying steady traction in the downward direction. The buttocks then follow, and flexion of the spine occurs at the thoracolumbar region. You're essentially delivering the baby like a footling breech. Once the trunk is out, the head tends to follow with some upwards traction. It's really important that you avoid hyperextension of the fetal neck and forceful pulling on the neck to avoid any fetal injuries. Now, there's actually some evidence to suggest that a reverse breech extraction results in less maternal trauma than the push method with an assistant's hand.
The final technique is called Patwarden's method. Hopefully I'm saying that correctly. This involved delivery of both fetal shoulders and the arms through the incision, followed by the trunk, breech, and then finally lifting the head out of the pelvis. Both the reverse breech extraction and Patwarden's maneuver are technically difficult and may involve extending your uterine incision, either an inverted T or a J. It's really surgeon's preference here.
There are some other novel devices that have been described to assist disimpaction of an impacted fetal head, including the Tiedemann tube, the C-snorkel, and fetal head elevating devices, otherwise known as obstetric spoons. However, there is not enough evidence to recommend their use. The Tiedemann tube, which is probably one of the more recent inventions, is a hollow silicone tube with a rounded cup that's inserted vaginally to elevate the fetal head. It's designed to reduce the amount of pressure exerted on the fetal head compared with digital or hand vaginal push-up and with the fetal pillow. Now, this device would be helpful for unexpected impacted fetal head rather than using an assistant's hand, but unfortunately more research is needed before use in a clinical setting. The C-snorkel is a tube with ventilation ports designed to release the vacuum between the fetal head and the vaginal wall. Unfortunately, this was found to be ineffective and subsequently was removed from the market. Now, obstetric spoons, like the Coin spoon, Selheim spoon, and the Merlis head extractor, which look like a single blade of an obstetric forceps, were originally developed in the 1950s. However, their use has fallen out of favour due to lack of evidence, absence of safety data, and the risk of them being used improperly, which might result in maternal injury. Now, they essentially function like shoehorns. Not that I expect any of our listeners have ever used a shoehorn.
However, this is an extremely stressful situation. May we never need to do those maneuvers. But it is good to go through them in your mind, or maybe with a model in case you are in that situation. There is actually a model called Desperate Deborah, which simulates an impacted fetal head. Always know your plan B and C and D. Now, once you've gotten that baby out safely, don't forget your post-op considerations. Always anticipate a postpartum hemorrhage and neonatal resuscitation. All right, so let's do a quick summary. A deeply impacted head is where the fetal head is wedged deep in the pelvis and standard maneuvers aren't enough to get it out. Anticipate an impacted head if it's a fully dilated, low fetal station, prolonged labour, oxytocin use, obstructed labour, or malposition. Ideally, have a paediatrician and a consultant obstetrician in the room. Ensure adequate access and place your uterine incision high on the uterus. Consider your push techniques. Go lateral, use your non-dominant hand, insert a fetal pillow, have an assistant push up with a cupped hand, never flex your wrist, and consider the reverse breech extraction or pull method, and finally, the Patwarden's shoulders first method. Now, let's move on to the opposite of an impacted fetal head, a floating fetal head.
Yes, the floating head. Now, you'd think a floating head would be quite easy to deliver. However, those babies are quite slippery and you really can't just grasp and pull the head down towards the incision. Plus, fundal pressure just tends to push the head laterally rather than towards a uterine incision. A floating head is defined as a station of -3 or above. There are two main options for managing the floating head at Caesarean: internal pedalic version followed by breech extraction, or vacuum or forceps.
Internal pedalic version with breech extraction is different from reverse breech extraction of the impacted head because the fetus is internally verted from cephalic to breech presentation before extracting most of the body. Basically, you reach into the uterus, grab one or both feet, and pull them through the hysterotomy while using your other hand to guide the head to the fundus. This causes the baby to rotate from a cephalic to a footling breech presentation. Now, you want to be sure you're grabbing a foot and not a hand here. It can be a right cacophony if you keep pulling out a hand. The trick is to feel for the heel. If you accidentally grasp a hand instead of a foot, gently replace it into the uterus and try again.
You can also apply a vacuum cup to the flexion point or apply forceps to help deliver the baby. One thing I found useful with a floating head is to break the water slowly after your uterine incision and allow the head to come down towards the incision as the amniotic fluid drains.
Okay, let's talk about the next category of complex caesareans, the extremely low birth weight baby. Low birth weight babies are typically preterm or very small, and so their bones and soft tissues are more delicate and prone to injury. It's really important that you're really gentle with these babies. Only hold them by bony body parts and use slow, controlled movements for delivery. It can even be helpful to deliver the baby on call to minimize trauma. You want to really minimize handling of these babies. But then what about our big babies? What are our considerations for delivery with these babies?
Believe it or not, but macrosomic babies can still have a shoulder dystocia at caesarean section, and this can unfortunately result in a brachial plexus injury or fracture. Now, this is much less likely to happen with a caesarean section than a vaginal birth, but you still need to be aware of it. The principles of delivering a macrosomic baby include ensuring you have a large enough incision. Typically, fully dilated, malpresentation, big baby, small baby, do a big incision. And consider extending your uterine incision into a J or a T to create additional space, or better yet, starting with a classical incision if you're expecting a very macrosomic fetus. You may even need to consider delivery of the posterior arm for these babies.
But then, what about our breech babies, our next category of difficult babies to deliver?
Breech babies are some of my favourite babies to deliver. So the first
I disagree.
So the first thing you want to do is identify the type of breech. Is it footling, complete, or frank? And you want to know where the back is as well. So you can usually do this with a bedside ultrasound prior to delivery. Or if the breech is unexpected, you might be able to identify the presenting part by palpating the uterus before you make your incision. Now, be really careful with your uterine incision. The fetal buttocks is quite soft and sits very close to the uterine wall, so it can be really prone to laceration when you do make your uterine incision. So try to enter the uterus with a blunt technique, and you can even leave the membranes intact if possible, which may help prevent any fetal injury and help you grab that presenting part. Now, when delivering a breech, you would typically grasp the buttocks and elevate it to the uterine incision as you would if you were delivering the baby cephalic, but you want to make sure that you keep the fetal back up. If it's a footling breech, then you would try keep the membranes intact, grasp one or both feet, and deliver the baby by the ankles. Remember, you can identify a foot versus a hand by the presence of the heel. We then apply steady downward traction while only grasping the bony prominences of the hips. You really want to avoid putting any pressure on the soft abdomen, which can result in internal organ injury. Deliver the fetus in a horizontal direction towards the maternal feet until the bottom of the scapula is visible. Now, usually the legs will deliver spontaneously. However, if they don't, you can use Pinard's maneuver. This is where you place one finger in the popliteal fossa, resulting in external rotation of the thigh and flexion of the knees to allow delivery. Loveset's maneuver is then used to deliver the fetal arms. So remember, that's when you rotate the fetus gently to each side to allow the shoulder to come free, and then gently flex the fetal elbow to aid delivery of the fetal arms. Then we get to the head. So ideally, you would usually have your assistant applying gentle pressure to the fundus to flex the fetal head throughout the breech delivery in order to prevent head extension and an entrapped head. The head should then be quite simple to come down with ongoing gentle traction. I usually warn the parents that breech babies can be born a little flat. They are often a little surprised to be delivered upside down, and they may not cry straight away, and this can be very normal. I think preparing the parents for this is important because it's always really scary if your baby is born and doesn't cry the house down immediately.
The main issue we worry about with a breech delivery is an entrapped head, which is also one of our major concerns with a vaginal breech delivery. Whilst caesarean section for breech is generally considered to have a lower chance of fetal trauma when compared with vaginal birth, there are still fetal risks of trauma and asphyxia, and also of maternal trauma. Breech babies are still at risk of cervical spine, spinal cord, and/or vertebral artery injury following delivery of the aftercoming head. These injuries typically occur after hyperextension of the cervical spine, but it's important to note that these injuries can also occur antenatally and are not always due to the delivery itself. If the fetal head is hyperextended antenatally, then the C-spine can develop abnormally, which can predispose the breech baby to hyperextension injuries.
The key to successful delivery of the aftercoming head of the breech presentation is to maintain head flexion during delivery of the limbs and torso. Again, you want to make sure your incision is large enough to allow access and the necessary breech maneuvers. If your baby doesn't come with simple downward pressure on the uterine fundus, you can use a modified macrosomic V maneuver or obstetric forceps, but only if the head is low. If the entrapped head is still high, then you want to consider tocolysis and extension of the uterine incision, typically an inverted T incision. When performing a forceps or MSV maneuver, you would get your assistant to hold the baby upright so you can perform delivery of the head, being really careful to avoid hyperextension of the fetal neck. The MSV technique involves placing the first and third fingers of one hand on the fetal cheekbones, placing the second finger in the fetal mouth and pulling the jaw down, while placing two fingers on the back of the baby's neck and occiput to aid flexion. If this doesn't work, you can use forceps.
Oh, and don't forget your tocolysis. GTN can help relax the uterus, which might make delivery of that head a little bit easier.
The other type of malpresentation to consider is the baby in transverse lie. Now, if the baby is transverse lie back up, you can simply grasp the feet and go for a footling breech extraction. Leaving the membranes intact after a hysterotomy can give you enough time and space to find and grasp the fetal foot before the membranes are ruptured and the uterus clamps down. Transverse back down babies are much more difficult to deliver because the fetal feet are usually difficult to grasp. In this situation, you could try an ECV before starting the Caesar or an intra-abdominal version before making the uterine incision in order to convert the baby to a breech or cephalic presentation. The assistant would then hold the fetus in the longitudinal position while the hysterotomy is made and the fetus is delivered. You may want to consider a classical caesarean for the back-down transverse lie, or even a lower segment vertical incision, although most babies can be delivered through a transverse incision. On that note, let's touch on the classical caesarean. What is a classical caesarean section?
So a classical caesarean involves a transverse incision on the abdomen, but a vertical incision on the uterus that extends into the upper uterine segment towards the fundus. Situations where you might consider a classical caesarean section include a preterm delivery with a poorly formed lower segment, ruptured membranes with transverse lie back down, anterior placenta previa or accreta, lower segment or cervical fibroids, fetal abnormalities such as conjoined twins, hydrocephaly, sacrococcygeal tumour, for example, in the case of very densely adherent bladder, or when you're trying to deliver a very large fetus. So we're talking anomalous or extreme macrosomia here. And this is where there is a high risk of extension of a transverse incision into the uterine vessels, or where you might require a T or J extension to extract the fetus. Classical caesarean sections are important to know about because not only is the surgical technique different, but there are also inherent different risks with the classical caesarean section. Classical C-sections have an increased risk of blood loss, transfusion, endometritis, and post-operative adhesions. But by far, the most serious complication is uterine rupture with subsequent pregnancy, which is quoted in the literature as anywhere between 1 and 12%. For this reason, a classical caesarean section is considered to be a contraindication to a vaginal birth in future pregnancies. There is also an increased risk of placental anomalies, such as placenta accreta spectrum.
The repair of a classical caesarean is also different. We typically use a 3-layer closure with a baseball stitch for the most superficial layer, mainly so we can close the dead space and ensure strength of our repair.
Okay, so that wraps up this week's episode on strategies for difficult deliveries. We've covered the entrapped head, extreme prematurity, fetal macrosomia, breech and transverse lie, and classical caesareans. The key takeaway messages would be to anticipate the difficult delivery, to use an ultrasound to identify the presenting part and where the fetal back is, to have a consultant and pediatric support, to notify the anaesthetist in advance that tocolysis may be needed, to have a plan for delivery and then a bunch of backup plans in case they don't work, and to always anticipate complications like uterine extension, postpartum hemorrhage, or neonatal resuscitation.
Thanks for listening to the Uterine Sound. We hope you found this week's episode helpful. As always, you can find us on Instagram at The Uterine Sound, our website, theuterinesound.com, and you can email us on theuterinesound@gmail.com.
Feel free to let us know if you have any tips for the difficult caesarean section.